Good morning. Welcome everyone to the Crohn's and Colitis Foundation Northwest Chapter Spring Patient and Caregiver Education Webinar. My name is Jody DeLay, and I am the Education Support and Advocacy Manager for Washington and Oregon. It's my pleasure to be here with you all today. I'm so thankful to you for joining this morning from your living rooms and offices all around the Pacific Northwest and beyond. Well, we are certainly in unprecedented times. It's been really exciting actually to get out of our comfort zone and find new ways to communicate and to be in contact with all of our patients and others. And so we really appreciate your adapting with us. We believe that we have created today an agenda that has a little bit of something for everyone, and we hope that each of you learns something new. Before we get started, I wanted to take a minute to thank our Chapter Medical Advisory Committee. This group is made up of physicians, gastroenterologists, dietitians, mental health specialists, nurses, all kinds of healthcare specialists who work really year-round to make sure that the information that we're providing is accurate, that we have the most recent regional updates, that both the programming and the resources that we put out are current. They are fundamentally part of every education program that we do. And so we're just really, really thankful to them for all of their work, especially during these unique and ever-changing times. We know that they're pulled in a lot of different directions. So I thank all of them and all of the doctors, nurses, ancillary providers that are really working so hard during these times. Without them, and then also the volunteers for the foundation who come together, they stuff packets, they send envelopes, they provide promotion of all sorts of things that we do, we just wouldn't be able to put on these programmings. Finally, I want to thank our sponsors. Janssen, Swedish, Takeda, and Washington Gastroenterology are funding our program today, and we truly do need their financial support to provide the education mission that's part of our foundation. So with no further ado, I want to go ahead and go ahead with a couple of quick announcements for today's program. First of all, even though we're not all together and we're unable to interact personally, we do want this to be an interactive presentation. So please ask your questions into the comment box during the presentation. Following each presentation, we will have an opportunity where our moderator will read them out and answer the questions. So please put your questions in the box. All of your microphones are muted to enhance the listening quality for everyone, but we still want to hear from you, so don't be shy with those questions. I don't need to share where the restrooms are since you probably already know, but I will note that we are recording these sessions today. So if you miss something, there will be reruns available for you. Following the event, you will also receive an evaluation form. So please take a moment to complete that, as it will help us to prepare for our fall program, as well as to improve our delivery through these new sorts of means.
Jody, I'm sorry to interrupt. You're not sharing your slides, so you may want to share your screen, please.
Oh, I'm so sorry. I thought I was the...
He's sharing it with us.
Yeah, it says I'm sharing my screen. Sorry about that. I can't. It says I'm sharing it. So we'll just move on to Dr. Chiorean. If you want to get your screens ready, then I'll be prepared to transfer. Before I move to Dr. Chiorean, though, I want to introduce our moderator. The Seattle is Dr. Elisa Bowden with the Virginia Mason Medical Center. Elisa is a gastroenterologist specializing in inflammatory bowel disease who sees patients at Virginia Mason Medical Center. Her areas of expertise include Crohn's disease, celiac disease, and ulcerative colitis. She is also a basic and clinical researcher with Benaroya Research Institute at Virginia Mason. Dr. Bowden is a member of the Crohn's and Colitis Foundation Chapter Medical Advisory Committee and is our moderator and one of our course chairs for today's event. Dr. Bowden, I will turn it over to you to introduce our first presentation. And Dr. Chiorean, I am getting ready to share your screen.
So again, I just wanted to thank everyone so much for being here in a time when we are required to be physically distant. It's really wonderful to continue to have the support of the Crohn's and Colitis Foundation to keep us socially connected. And I want to thank the organizers and presenters and all of you participants who have pivoted and made this educational opportunity available despite some of our challenges. I have a great pleasure of introducing my partner today, Dr. Michael Chiorean, who is the course chair of this educational program. He is a gastroenterologist at Virginia Mason Hospital, where he's the director of the Inflammatory Bowel Disease Center of Excellence within the Digestive Disease Institute. He's really a champion for clinical trials. He did all of his training at the prestigious Mayo Clinic, and he is chair of the Crohn's and Colitis Foundation's Medical Advisory Committee and also sits on the board of trustees of the Northwest chapter. He's going to help us understand the COVID-19 pandemic with his presentation this morning. Take it away, Michael.
Thank you very much, Elisa and Jody and the rest of the Northwest chapter. Okay, I think you should have my screen right now, right?
Yes, we just need you to put it into presenter view. Yep.
So yes, thank you everybody for participating. I see we already have 75 attendees, which is outstanding. So I would like to thank Jody, who did a tremendous job organizing this event and switching in a record time from a live to a webinar format. And obviously, I'd like to thank the rest of the faculty who contributed their time and knowledge to this patient education experience. Also our sponsors, Washington GI, Swedish Janssen, and Takeda. So without further delay, I was tasked to talk to you about obviously a very hot topic nowadays, COVID and IBD. Before we start, again, if you have any questions, you have a chat box there on the right. You can ask your questions along the way. If there is anything that catches my eye, I will try to respond right away verbally. But if not, we're going to address most of your questions at the end of the presentation. Again, don't hesitate to ask the questions along the way so you don't forget them, and we will tackle them either during the talk or at the end. There is an option, I believe, to raise your hand. That may not be so practical during the talk, so don't raise your hands because we may not be able to see them. I'd rather you write your question in that chat box that you have on the right banner. So COVID and IBD, obviously hot topic. These are my disclosures. What I'm going to cover in the next 30 minutes or so is what is COVID-19? How does it affect IBD patients? How should IBD patients balance the risk of the disease and disease control and infection prevention? And what are the current expert recommendations regarding IBD and COVID? So in terms of background, coronaviruses have existed for obviously a very, very long time. They're a large family of RNA viruses. This is an important distinction because influenza is also an RNA virus. And as you probably have seen in the news, there have been several comparison drawn between these two diseases. So we're going to talk about side-by-side comparisons a little bit later. They're extremely widespread, both human and animal kingdom, and they cause illnesses from common colds to pneumonia, as everybody knows. There are multiple genera, of which alpha and beta can cause human disease. Alpha are by far more frequent, so these are some of the most frequent causes of common cold during the winter months in humans. And then the beta are less common, but obviously more famous because they have caused these fairly important outbreaks over the last 2 decades, starting with SARS in 2002, 2004, which was confined primarily to Asia and Canada. And then MERS, the Middle Eastern respiratory, severe respiratory syndrome, that was in 2012, 2013, also very confined. And then finally, a pandemic, the COVID-19 from 2019 and 2020. What's important for coronaviruses in general and beta in particular is these are primarily, they're very popular basically in bats. So beta is able to mutate and therefore jump between species, and this is how we believe it got to humans. Generally, they need an intermediate host. So the bats apparently cannot transmit it to humans, even if we share the same receptor for the virus in the respiratory tract. They need basically 2 mutations, so 1 intermediate step before they can actually jump to us. In 2002, that intermediate step was thought to be the civet, which you see in there in the picture in the right upper corner. The MERS outbreak in 2012-13 was thought to be a camel, or was demonstrated to be a camel. And then finally, we think that, or some experts believe that in 2019, that intermediate stepping stone was the pangolin, which is the most traded wild animal in China. Apparently, it's considered a delicacy there. So, glossary of terms so that we all understand what we're talking about. So, COVID is the disease. Coronavirus disease 2019, even if most of the cases happen in 2020. SARS-CoV-2 is the virus that causes the disease. Isolation means separating an individual with the disease. So somebody who has a positive test, whether or not they have symptoms, we're separating them from the rest of the crowd so they don't infect other individuals. Quarantines instead means separating an exposed individual without the disease. The term quarantine actually comes from quarenta, which is a Venetian for 40. And basically, as you may imagine, this comes way back from the Black Death, so the bubonic plague epidemics in the 13th century, when both passengers and crews on the ships headed for Venice had to stop on an island just outside of Venice. It's now actually available for tourism. Well, maybe not now, but in a few months it will be. And they had to wait there for 40 days to make sure that nobody developed the plague. It was a obviously very lethal disease. It is estimated about 40% of the population died with the worst of these outbreaks, and there were about 5 in history. So you can imagine what kind of measures these people had to take at that time when they had no idea about what was the cause of the disease, and obviously they had no treatment for it. So, but importantly, quarantine as an individual without the disease was separated from the rest of the crowd until they are ruled out or ruled in for an infection. So what do we know about this coronavirus? The spikes give it the name corona or crown, and they help the virus attach to a special protein in the respiratory tract. It's called ACE2. I'm not going to go into much detail about that. But it is also present in the intestine, although we're not sure what is the role or impact of the virus causing or not an infection in the intestine. It is, however, detectable in the stool of almost half of the individuals, as we'll see later. So SARS virus, SARS-CoV, has higher infectivity, meaning it spreads easier, but it has lower mortality compared to its cousins, both SARS-1 and MERS. So we call that the R0 or R0, and the value for SARS-CoV-2 is 2.5, meaning that each individual can infect 2.5 other folks who are healthy. So I'm showing here some comparisons between SARS-CoV-2, the current public enemy #1, and the other relevant viruses. So R0 2.5 to 3 for SARS-CoV-2 versus 1 to 2.5 for SARS-1 that was rebaptized recently into SARS-1, and MERS Influenza A, so the flu has a 1.5. Measles is very contagious, 13 to 15, and that has to do mostly with the fact that the incubation period is very long. So it takes about 3 weeks from the time you get infected until you develop symptoms. During that time, most of these folks are minimally symptomatic or they have non-specific symptoms, and therefore they very readily transmit the disease. Smallpox is also pretty high, 5 to 7. Mortality is also different. So SARS-CoV, the current guy, 2%, although based on some recent studies, both from New York, the pregnant women study from New York, and a study from Stanford that's currently in press, data from LA County and San Bernardino County suggest that the prevalence is much higher than we think, and therefore mortality could be quite a bit lower, potentially less than 1%, whereas both SARS and MERS were very lethal. SARS-1 was 10%, and MERS was particularly lethal at 38%, which is the reason why we believe it didn't spread quite so readily. In contrast, influenza has a much lower mortality of about 1 in 1,000. So what are the differences between flu or influenza and COVID-19? And these are just a handful, but again, the infectivity rate is higher for COVID at 2.5 versus about 1.3 for flu. Incubation time also seems to be longer. With COVID, up to 14 days. Median is about 5 days. This again is important as far as spreading, because a lot of the peak of the viremia, so the highest replication speed of the virus, is actually in the first few days when people are generally asymptomatic. That applies to every virus, not just to SARS-CoV-2. But because the incubation time for flu is so short, they don't have time to spread. Once they become sick, people isolate themselves instinctively. Whereas with COVID, it takes a bit longer for people to develop symptoms, so therefore they have more opportunities to spread it. Hospitalization rate, obviously big difference. And then mortality rate, we believe that it's about 10 times higher with COVID compared to flu. There are other important differences between flu and COVID. So first of all, because we lived with flu for hundreds of years, literally, if not thousands, and we've seen many epidemics, our body is innately protected. So we have some background resistance regardless of the strain, shift, or drift. Plus we have vaccinations which are relatively effective. So the wave, so to speak, the epidemic wave of flu progresses much slower in the population compared to COVID, with which we have absolutely no previous immunological experience. There's no vaccine. Nobody has ever seen it, at least not in this country. So that generated that idea of the wave of epidemic, which can overwhelm the healthcare system, and we have to flatten it somehow. Another very important difference, as we'll see in a little bit, is that flu, as opposed to COVID, can kill anybody. So it has no respect for age. If anything, it has a U-shaped curve. It kills primarily the very young and the very old. In fact, there was a recent story in the news about a twin pair. So the older twin was 100 years old last week, and he died of COVID, while his twin brother died when he was 1 year old of influenza in 1918. So very interesting observations as far as these two conditions. So this is that curve that I mentioned earlier, and this happens with a brand new virus that hits the community because we have no intrinsic or acquired immunity to this virus. It was anticipated that if left uncontrolled, the number of cases, in particular the number of cases that need intensive care, would overwhelm the healthcare system, and therefore by reducing the transmission by social distancing and the other hygiene measures, and eventually ending up with a lockdown, we would flatten the curve. And by flattening the curve, as you can see from that area under the curve, you're not actually reducing the cases, but you're spreading them out over a longer period of time so that the healthcare system can keep up with it. So 80% of COVID-19 patients are asymptomatic or develop mild disease. This is just like the other coronaviruses, almost indistinguishable from the common cold or mild flu. Fever is very common, cough is very common, other manifestations are there, headache, body aches, fatigue, and loss of smell of taste has been postulated. You lose your smell or taste basically with any upper respiratory illness or with allergies, but that has been listed as an early sign of COVID as well. It's not specific by any means, so you don't have to be very alarmed if with any respiratory illness you lose your taste or the ability to smell stuff. So indistinguishable from common URIs. But what's important here is with COVID is that the younger the patient, the milder the symptoms. Instead, 20% of patients develop more severe disease, including pneumonia, and the manifestations of that are shortness of breath, worsening cough, persistent fever, and then a minority, fortunately and unfortunately, develop acute respiratory distress syndrome or ARDS, and that is basically what kills people because this requires ventilatory support, and as you will see in a bit, a lot of people do not survive this. As far as the GI system, about a third of the patients with COVID can develop GI symptoms, including nausea, abdominal discomfort, and diarrhea. Very rarely, these symptoms have been the only manifestations or have preceded the respiratory illness by a few days. Most of these cases come from Asia. We have seen a handful here in the US as well, particularly in New York, but very, very, very rarely GI is the only manifestation of the disease. So keep in mind, 99% of the time, this is a respiratory illness with fever. The virus, on the other hand, can be detected in the stool in up to 55% of patients, but we're not sure if that's just RNA that's kind of floating around because there are no clear cases of fecal to oral transmission. So we know from all the studies performed so far that the only way the virus transmits is through these respiratory droplets that are generated when you cough, when you sneeze, and sometimes when you talk to somebody very closely. And thus that 6-foot distance that's recommended between folks. This is an interesting slide that's kind of trying to get to the mechanism of the 2 or 3 stages of disease and how we approach it differently. And it's a very busy slide, but I want you to focus on those phases. So in the early phase, this behaves like any other respiratory virus. It replicates in the upper or lower respiratory tract. It causes some symptoms, including fever, cough, and so on and so forth. And then 80% of people, for 80% of people, that's it. In 20% of people, this progresses into a pulmonary phase with pneumonia. So that's kind of that middle stage that happens after about a week or so. And that is also something that would support if therapy should get better. However, in a minority of patients, the body, the immune system, develops this exaggerated inflammatory response, which is called ARDS. So that's where the virus becomes less relevant and the immune system becomes more relevant. It's a hyperinflammation phase, like in any other tissue, and IBD patients should be particularly attuned to this because IBD is also a disease of an overactive immune system against a less known antigen. So in that situation, these folks develop an exaggerated immune response that in this case attacks the lung. It fills up with pus, with inflammatory cells, and that is called ARDS, respiratory failure. They need ventilated, and frequently, unfortunately, they die. So thus, if you look at the bottom of this, the potential therapies actually differ between the stages of disease. So in the early phase, we obviously don't have an antiviral therapy, but one day I'm sure we will. So that's where the medications that work against viruses, such as the case with influenza, for instance, where we use oseltamivir, would be effective. In the stage 2, also some antiviral therapy, but potentially anti-inflammatory therapies. And then in stage 3, the overactive immune response. That's where we're trying to figure out if there's anything we can do about this exaggerated immune response, including blockade of these mediators such as interleukin-6, 2, 1, and so forth. So whereas theoretically in the first phase, the viral phase, the goal would be to reduce immunosuppression to allow the immune system to fight the virus. For the last stage, it's exactly the opposite. We're trying to block the immune system so that it's less reactive and it causes less damage into the lungs. This is, again, still theoretical at this point, but it's a very interesting topic, and stay tuned because I'm sure there will be some developments in this regard. What are risk factors for severe COVID? Old age in virtually every study, every continent, every country, every setting, analyzed and reported. There are virtually the death rate is near 0 in people less than 30. Male gender, for some reason, seems to increase mortality. And then having comorbidities panned out to be a very important risk factor for this, including obesity, diabetes, hypertension, COPD, cystic fibrosis, heart failure, renal failure. Not so much, we really don't know much about cancer. And certainly immunodeficiency states was postulated to be a risk factor, but they scratched it off recently, and I'll show you why in just a second. So this is sort of a snapshot of patients hospitalized with COVID. This was recently published last week in JAMA, just to kind of give you an idea about what we see in high impact zones. So obviously New York was the epicenter of the disease in the United States. So they had a very large number of patients. And this is just one section of one hospital network. It's not the entire New York City. It's just the Norwell healthcare system, which covers maybe about 20% or so of the New York metropolitan area. So of the 5,000 or so patients that were hospitalized, they had outcomes in about half, 2,600 patients. Again, median age 60, ranges 0 to 107. These are all hospitalized, by the way. So almost 2/3 male. Multiple comorbidities were present in 88% of them. Interestingly enough, out of these 2,600 patients, there was only one transplant patient, and the other patients with autoimmune disorders were so few that they didn't even mention them. ICU admissions, about 14%. This is right on the money. If you look in Italy, France, Spain, or China, it's almost the same rate. Males slightly more likely to be in the ICU. Mechanical ventilation by the majority of patients who were admitted to the ICU, but no patient less than 18 required ventilation. And overall, out of those 2,600 patients, 21% died, so about a fifth. Mortality among ventilated ones was particularly high at 88%. No patient less than 20 died. Now, that 88% rate makes it sound terrible, almost like there is no point then in flattening the curve. If anybody who ends up in the ICU and is ventilated dies, we're not doing a good job anyway. But this is not something that really can be generalized to other areas. So at our institution at Virginia Mason, the mortality among ventilated patients was less than 50%. We're right around 50%. And from talking to our colleagues at the University of Washington and other large centers in Seattle, it seems to be right there at 50. There was another study from Kaiser in Northern California that was published yesterday, also showing a 50% mortality among ventilated patients. So while it's not obviously a small number, it is not as terrible as it sounds from this study. And I think the problem here has to do with the censoring of the cases. So stay tuned. I think, though, this is one of the areas where I have to make some effort, obviously. So either early on, finding a way to treat the virus or prevent the infection, but this is the other area that obviously has a lot of room for improvement, how to prevent mortality among patients or help to prevent progression to ARDS. So these two, if there is a take-home message as far as research and what the future holds, those are the two key questions for us. So who should be tested? I think that's another question that's out there in the community. So for virus, that's the famous nasal swab that everybody hates. Now apparently there's a saliva test that can be done. It hasn't penetrated yet in every center. But for virus, you have there the three priorities according to the NIH. So priority one, hospitalized patients, obviously no question about it, and symptomatic healthcare workers. Priority two, individuals who live in long-term care facilities and have symptoms, older than 65, underlying conditions, and symptomatic first responders. So still patients with symptoms. And then priority three, in communities with large outbreaks, such as New York, New Orleans, critical infrastructure workers, healthcare workers, first responders, and individuals with mild symptoms. So expansion to other individuals who are very important for the community. So that's where you may want to cast a broader net. However, in communities like us, Seattle, Northwest, and in fact, the entire West Coast, we're still only testing people who are symptomatic because it's unclear if widespread testing in the community would make any difference. For antibodies, which have now entered the market, there are no recommendations as to whom to test, but these would be more important from the epidemiological perspective, so understand who had the disease and therefore is now protected. Also, workers in high-risk professions such as healthcare, airline, service industry, where they should be allowed to return to work sooner if they have immune protection against the virus. And then as a note for both of these, remember that the test for virus, so the PCR nasal swab, has a very short validity of a few days. So the fact that you're negative today doesn't mean you're going to be negative in 2 days. You go out there in the park, you meet somebody, and literally this the positivity can change from day to day, whereas the antibodies are essentially forever, and they provide good immunity, we think. So recommendations as of now, no pre-exposure prophylaxis against the virus outside of a clinical trial, no post-exposure prophylaxis against the viral with medication outside of a clinical trial. The only thing that is recommended right now is social distancing for people who have not been exposed, and as I mentioned earlier, quarantine for people who have been exposed to make sure they don't develop symptoms. No additional lab testing and no treatment for people with confirmed asymptomatic or pre-symptomatic virus, so those who are PCR positive. And no drug has been proven to be safe and effective for treating COVID-19, despite of everything you've seen in the news recently. How about IBD and COVID? Obviously, this is a topic near and dear to our heart. So in data from China and Italy, which were the larger outbreaks until the United States, showed no increased incidence of COVID among patients with IBD. Also importantly, no increased risk of severe COVID among IBD patients. So this is one of those studies. This one is from Spain, actually. It was published last week. Small numbers, but truly, although these guys had 150,000 patients, what is very remarkable about this is that looking in every single database we had out there, so Spain, almost 200,000 cases, Italy, 200,000 cases, the United States, 800,000 or so, we were expecting 4 times as many patients with IBD to be either detected or hospitalized with COVID. So we saw a quarter of the expected number with IBD. I'm not saying here that IBD or treatment thereof protects against COVID. I think that would be the wrong conclusion. I think what we can begin to say, what is fair to say, is that there's probably no increased risk for COVID if you have IBD and if you're treated for it. But we'll see how that pans out in a little bit. So among these 40 patients, almost half were on immunosuppressive therapy. You see the breakdown there, immunomodulators and biologics. About a fifth reported diarrhea, half were hospitalized, none admitted to the ICU. There were 2 deaths, I listed them there. An older gentleman with prostate cancer, metastatic prostate cancer, who was on mesalamine, and a 77-year-old with dementia who was also on mesalamine. I apologize for these occasional interruptions. I'm also on call. So, and that gentleman was treated with mesalamine and methotrexate. So this is a slide that I compiled out of the global COVID IBD database. It's called the Secure IBD database. It's in the public domain. You can access it at that website listed in the footer note. And that's the, as of a few, 3-4 days ago, we had 704 patients globally. This is a voluntary enrollment, obviously, so not all cases in the world with IBD are listed here, but these are investigators, clinicians from different institutions who are putting the patients in. So 700 patients, and as you can see, basically the breakdown by age for hospitalization, ventilation, and death. And the important signal here is age. The older the age, the more likely they are to be hospitalized. Now, you can argue that hospitalization is somewhat subjective. Obviously, people in the ER and physicians in general are very leery about letting somebody go home if they have an infection like this. So a lower threshold to hospitalize. But ventilation and certainly death are very hard endpoints. And as you can see, virtually nobody below the age of 30 died, and very few patients less than 40 were actually in the ICU and ventilated, even if they were hospitalized. Conversely, some patients died without being put on a ventilator, so that has to do with likely with their poor overall health status before they got infected, the fact that they were DNR, so do not resuscitate, or they had other comorbidities that made them not very good candidates to be on a ventilator. So again, old age and comorbidities, strong signal. And I'm showing here a comparison with patients without IBD from Italy and China as of February and March respectively. And as you can see, almost the same breakdown. So number of deaths by age, the percentage is a little bit higher in Italy compared to the rest of the world, but it's about 20%. So this is non-IBD patients. China, around 15%. Virtually nobody less than 30 died of COVID, and the numbers were still fairly small up to the age of 50. These are now breakdown by sex and smoking status. So for some reason, males tend to do worse. We're not sure if that has to do with comorbidities or not, but that seems to be an independent predictor. And even if you disregard the hospitalization part, in almost every study, about 30% more males died compared to females. And smoking seems to be a risk factor. And obviously, you can make the logical association there by being a toxic or by injuring the lungs, the respiratory tract. Importantly, 4 times as many smokers died on a ventilator compared to non-smokers. And that's among IBD patients. So this is the other part that has a very strong signal, and that's the number of comorbidities. So for hospitalizations, ventilator, and death, a dose response curve there with a number of comorbidities. Virtually no patient with no comorbidities died. So that includes diabetes, hypertension, obesity, COPD, versus about 20% of folks who had 3 or more comorbidities. So this is a very strong signal that permeates across all studies, all countries, all continents, and all populations, not just IBD. So importantly now, this is a breakdown by medication class from the same registry. So in this overall population, about a quarter were on 5-ASA alone, about 10% were receiving steroids, 10% immunomodulators, a third an anti-TNF biologic with or without the immunomodulator, about 17% were, I put there Entyvio or Stelara so that people don't get confused about the generic names, but that's vedolizumab or ustekinumab. And then a minority were on other therapeutics, including tofacitinib or Xeljanz or other immune modulators. And still about essentially 2/3 of patients who died were only on 5-ASA and or steroids. So that's again the effect of age and comorbidities and not the medication. Those are very slight signal for steroids. So 13% versus less than % with the other drugs. We're really not sure if that's the medication or the active disease that we were treating. Why do we say the steroids are bad? We're extrapolating a little bit. So we know that, for instance, prednisone can make influenza A worse. Influenza is an RNA virus, so it's very easy to extrapolate to SARS-CoV-2. And then we know that people who had SARS-1, so the cousin of the current virus, and MERS, had prolonged viremia and prolonged shedding of the virus if they were on corticosteroids. So we're extrapolating to COVID-19, even if there is no strong evidence that steroids are actually bad. But be it as it may, this is where we put our recommendations. So no increased risk of COVID complications with any medication group. Older patients and patients with comorbidities are more likely to be on 5-ASA and steroids and more likely to have complications, including need for ventilatory support and death. And so therefore, the risk of complications is driven primarily by these two factors, perhaps male gender, and not by the disease itself, so not by IBD or the medications used to treat it. So what do the experts say? So IOIBD is the International Organization for Inflammatory Bowel Disease, 30 experts from multiple countries, Europe, Asia, and the United States. And they met recently to come up, and they're updating these guidelines very regularly. So you can check this online at ioibd.org. And these are out of the 63 statements, I selected the 6 more important ones. Having IBD does not increase COVID risk. It is safe to receive treatment in an infusion center if there is a screening protocol in place in that infusion center. What that means, temperature check, masks, social distancing, and everything that can be checked on an individual basis. Appropriate to reduce the dose of prednisone to decrease the risk of infection. Inappropriate to reduce the dose of other medications. Elective procedures, so colonoscopy for surveillance, should be postponed. However, urgent procedures, so for instance, to diagnose somebody who has a severe flare or to diagnose complications, is not appropriate. Patients in clinical trials should continue with their clinical trial because oftentimes they have no other options and they may end up on steroids, which is probably a worse option from the virus standpoint compared to whatever treatment is proposed. Talking about general precautions and preventions, I think you have seen this in almost every outlet, TV, newspaper, but remember, washing hands is probably by far the most common. And the second one I would put there is being the face mask. Now, the face mask protects you if you're very close to a person who is ill, for instance. But I think the most important part of protection that comes from a face mask is it prevents people from touching their face unless they put and they remove their mask inappropriately. So the way this virus gets into your body, into your respiratory tract, is through these respiratory droplets from somebody who's sneezing nearby. If you have a mask, you should be able to shield at least some of that. But the next part is you're touching something that was touched recently by somebody with an infection, then you touch your face. And that's how the virus will find its way in. Everything else, important but less important, including the keeping your surfaces clean. If you have nobody in your household with COVID, cleaning your surfaces is good as a principle, but it's not going to protect you against COVID since you don't have it. It's not like it's in the air or it's in the air conditioning or so. In a hospital, that's a different story. Learn how to cover your cough or sneeze. That's important from now on for the next 100 years, I suppose, not just for COVID. And then social distancing, we're touting that mostly because it's probably going to be more important as the communities are lifting this lockdown situation. So recommendations regarding IBD meds, they're listed here. I kind of partially reviewed them there. Aminosalicylates and antibiotics are not immunosuppressive, so obviously do not discontinue. Immunomodulators take as prescribed unless the patient develops an infection. And that applies to thiopurines, methotrexate, biologics, JAK inhibitors. Steroids, do not adjust the dose without talking to your doctor, but generally we're very cautious about using high doses currently in IBD patients because of a possible risk of worse disease. So a note about steroids. Steroids are not maintenance medications. As I said earlier, based on research from SARS and MERS, it may make patients worse. It is prudent to reduce the dose if you're exposed or infected, and it's safe from the IBD standpoint, with the following caveats. Don't stop them suddenly because you can become very sick. Discuss steroid tapering strategies with your provider, and also discuss the risks and benefits of using the dose or reducing the dose of corticosteroids. As far as children, most cases in kids, as opposed to flu, have been mild or asymptomatic. So the reason the schools were closed is a reflex, a knee-jerk reflex. Oftentimes these guys are asymptomatic carriers. They have mild symptoms, and therefore it was thought that they help propagate the disease in the community, including among older people and particularly skilled nursing facility residents where the mortality has been particularly high. Now, a recent study from Oxford essentially looked back 20 years ago, data from China, Hong Kong, Singapore, and basically analyzed what the impact of school closure. All those countries basically shut down schools in the high impact areas immediately. And they showed that school closure did not contribute to the control of the SARS-1 epidemic. And modeling by these British researchers showed that COVID-2 related school closing may prevent only 2% of the deaths. So if the death rate right now is 2%, that would be 0.04% of the deaths will be prevented by school closure, which is significantly less of an impact than social distancing, isolation, washing your hands, and so forth. So question mark there, but it is what it is. Importantly, again, younger individuals less than 20 either never get hospitalized, or even if they get hospitalized, almost never have serious issues from COVID-19. Same medication and recommendations otherwise apply to IBD patients who are young. Emotional and mental health is particularly important. If anything, the lockdown has caused an undue strain on our affect. So try to limit your exposure to media. You've already seen everything you need to see. It's hardly any important news that comes out, and if there is an important news, it'll be on the Crohn's and Colitis Foundation website. Remember that all media sites sell by selling bad news. So they're designed to cause anxiety, otherwise people would not watch them. Good news very seldom sell. How many people know that the NFL draft was last week? Probably not too many. I hope you do. Make sure you have supplies, but don't hoard. Ask your healthcare team about risks. Find coping mechanisms that work for you, whether it's online, friends, or where possible live, family, friends, and so forth. Enjoy fresh air, maintaining social distancing, exercise, yoga seems to be very effective. Use the apps, Calm, Pray, and find support, very important. Friends or family, they're always there, but your Crohn's and Colitis Foundation friends and family are certainly always here, live or online. Important questions came about infusion centers. So yes, infusion centers are safe as long as they have a screening protocol in place, and most of them should have, the commercial ones and the hospital-based ones, with temperature checks and symptoms and so forth. You want to make sure that they can assure adequate social spacing, at least 6 feet between chairs. Can they provide masks? If they don't provide masks, bring one with you. Home infusions are not necessarily safer than infusion centers. I'm trying to drive this message through that is the same nurse that goes from home to home, and then she maybe visit 10 people. I'm not sure exactly how that would be safer than a commercial or hospital-based infusion system. And that's why I'm not gonna say that that's a safer, and I don't think anybody does, that's a safer option compared to a standard infusion center. So several unanswered questions about SARS-CoV and COVID. From the public health perspective, what is the inoculum size and transmissibility? So if you just catch one virus, almost certainly you're not gonna get the disease. If you catch 10, you're probably nothing's going to happen to you. So what is the size of inoculum? How much virus has to get into your body so that you get an infection? That's a very important question that we'll have to answer in the near future, actually, as we're trying to reopen the country. What's the true prevalence of disease? We were using numbers based on PCR, but as you know, testing has not been available until recently. I think when the widespread antibody testing will come into use, we'll really know what the true prevalence of the disease is. And as I mentioned earlier, the study from Stanford showed that in LA County, which has something like 10 million people, they found positive antibodies in 4% of the population. California reported 30,000 patients, so that's a 50 times order of magnitude compared to PCR. So not solid data, but stay tuned. I'm pretty sure this is going to change. What's important, though, is if the prevalence is so much higher than we think, then mortality is going to be much, much lower as well. So what's the protection through immunity? And we think that's going to be shown to be solid. What's the mutation rate? So like any other RNA virus, this guy can shift and drift. So how is that going to impact vaccines and immunity? We'll have to find out. For the scientific community, why the age-gender interaction? I think that's a very important question, particularly since this seems to be an immune response, not so much just the virus. What's the role of antivirals current, which we really don't know. We have borrowed some antiviral therapy from HIV and hepatitis C that are currently in trials, but I think future antivirals will give us a pretty solid answer here. The role of anti-inflammatory drugs, immunosuppressive drugs, we're trying to sort that out as well, particularly the IL-6 blockers, and there are some trials underway with that. The vaccine is very far away, despite everything you heard and you probably, people probably hope, at the minimum a year away. And even if we have a vaccine, it's very hard to prove that a vaccine is effective, because yes, you give it to somebody, you see antibodies. Well, we see that with infection too. But then how are you going to prove that that's protective? You're going to have to send these people into a community with high COVID. So it's good, but it's going to be a late player in this game. However, the vaccine is going to be a far more important long-term player for prevention of future outbreaks. And so here are some websites for you, both CCF and non-CCF related. We like our CCF one because it's updated regularly, and you can find almost any information you need to know about COVID and IBD. Thank you very much. That was my last slide. I will be very happy to entertain any questions.
Hi, thank you, Dr. Chiorean. That was an amazing talk and so timely. People have lots of questions about it. I wanted to start out asking you a quick question, which is, if our patients think that they may have symptoms of COVID, what should they do?
So very, very good question. First thing is call your provider. If you have a primary care provider, that would be a very good first resource. If you do not have a primary care provider, as it happens sometimes with young IBD patients, call us. And on a case-to-case basis, we will decide with you if testing is necessary. As testing for the virus has become more and more available, basically it's available now on a wider scale. I think more patients will be tested than not. But first thing you do, don't show up to an ER unless you have respiratory symptoms, shortness of breath, severe cough, or you have an underlying lung disease. Call your provider first. They'll help you decide if a testing is necessary. They'll help you decide if presenting to an ER is necessary, and then go from there.
Okay, great. We have some questions from the audience here. So one of the questions is if there are any extra precautions beyond the ones that you discussed for patients who are on immune suppressive therapies.
Yeah, well, so this kind of harkens back to what we've been saying for many, many years, and I'm glad you brought this up. If anything, I think COVID is going to draw the signal about immunization. So obviously for flu, it's too late now. What's interesting actually is that flu this year killed 60,000 Americans, including 180 some children. But the rate of flu vaccine, so people getting the flu shot, has spiked between February and March. So I think the fear of COVID drives sort of the good preventative measures for other infectious diseases as well. So yes, make sure you're up to date with all your vaccines. It's too late for flu, but pneumonia vaccine is very important. And those folks who are immunosuppressed, also the inactivated shingles vaccine. If and when your community will open up, if you go out there in the community, do the same things that basically you're doing right now. So keep the social distance whenever possible, wear a mask where the situation is crowded and less controllable, such as grocery shopping, so supermarkets. Wash your hands, don't touch your face. If you do that, you've covered probably 99% of the ways this virus spreads.
In follow-up to that, Michael, one of our questions was, if you get infected with COVID-19 and you've been immunized against pneumonia, is there any evidence that that helps you do better?
Absolutely not. So pneumonia is a bacterial infection caused by strep pneumo, and while it's not uncommon and deadly, immunization against pneumonia will not really protect you against COVID. Now, that said, at our institution, of the people who were hospitalized and admitted to the ICU and developed the ARDS, 1 out of 3 developed a strep pneumonia. So of those people, yes, in those cases, a pneumonia vaccine will be helpful, but in other situations, sort of community-wide, vaccination for pneumonia is not protective against COVID.
Okay, a few more questions here, Michael.
Go for it.
One question is, when they talk about diabetes being a risk factor, is that only type 2 diabetes, or would type 1 diabetes, which we often see in some of our patients who also have inflammatory bowel disease, also be a risk factor?
That's an excellent question. And I don't think despite these multiple studies across the board, nobody really has done the breakdown of type 1 versus type 2. Now, I'm going to put my 2 cents here. So in almost every study, if you look at the people admitted to the ICU and deaths, more than 2/3 were actually overweight. So obese, actually. So BMI over 35. So my hunch is that the type 2 diabetics tend to fare worse. And I'm extrapolating that also looking at the age bracket. So the fact that no patient less than 30, at least with IBD, and across the world, actually, with or without IBD, had a very bad outcome. And that's whereas type 1 diabetes is usually a disease that's diagnosed in childhood. So that suggests that it may not be so much the effect of diabetes, but the diabetes with other comorbidities, or diabetes that's not well controlled. So well-controlled type 1 diabetes probably has lower risk than poorly controlled type 2 diabetes associated with obesity.
Excellent. Okay. Why do you think that if we're only testing people who have symptoms at this point, why do you think the testing rate is coming back with a high number of negatives? What does that mean?
And that's because, again, if you look at the big picture, even today, COVID infections represent barely 10%, not even 10% of the respiratory infections in the community. So until March, until the end of March, we still had influenza. There were 50 million cases of influenza A in the United States between October 1st and March 31st. That is 50 times more than COVID. And then the cousin of SARS-CoV, so the coronavirus is A alpha that caused the common cold. They're also about 5-6 times more common compared to COVID. So when we looked at patients coming through our ER with upper respiratory symptoms, we detected viruses like rhinovirus, adenovirus, corona, and flu in a much larger proportion of patients compared to COVID. And sometimes we don't detect the virus because it could be something that hasn't been studied yet or hasn't been defined yet. But even so, out there in the communities at large, COVID represents at best 10% of the respiratory illnesses that go through the population.
Great. How do you foresee the presence of coronavirus in the population changing how you follow your patients in the long term? So in terms of follow-up, routine scopes, do you think we'll be relying more on laboratory values or other means for assessing disease activity?
So yeah, I'm gonna quote here Yogi Berra. It's hard to predict. It's hard to make predictions, especially about the future. It's not gonna be the same game we used to play before February, that's for sure. So right now we're making preparations to reopen our facilities for elective procedures and semi-elective procedures. I think one way or another, every patient coming in will be tested in some way, and whether that's with temperature checks, with these rapid COVID tests that result in 2 hours, or the more traditional RNA. In the first phase after reopening, because of the fear about a second wave, I think every patient having a procedure will be tested. In the long run, that is the $1 million, probably more like the $1 billion question. I think as we're learning more and more about this, and as medical therapy first and then a vaccine later will become available, things will change. Will we go back to 2019 scenario? Quite possible, but that's more like in the 4 or 5 year time horizon. I think in the next couple of years, people will still be very careful. There'll be some screening, surveillance along the way, and perhaps post-exposure prophylaxis with antiviral will be readily available by 2021 or so.
2 questions about antibodies. So one person is asking, the World Health Organization said yesterday that there was no scientific evidence that having antibodies protects you from future infection. And also in China, some people seem to be able to be infected twice. What do we know about antibodies and protection?
So I'm going to start with the second question first. There is absolutely no evidence from China, Europe, or the United States that people can be infected twice. People can still carry the virus up to 4 weeks after they had the infection, but they are asymptomatic. So is that some kind of a leftover limpy virus that's unable to do anything, but still populating the nasal cavities, the upper airway tract? Is it still transmissible to other people? We really don't know. What we know is that out of almost 3 million people infected in the world, there's no well-documented case of an individual who got the infection twice. You may be viremic, or you may still carry the virus, but after the first disease period, whether that's 14 days or 3 weeks or 3 days, there is absolutely no evidence that anybody got the disease twice. As far as the WHO does the best it can with the available evidence. Remember, the WHO on January 15 said that there is no person-to-person transmission, only animal-to-human transmission, and basically, even as of January 31st, they weren't really convinced that this was going to become a pandemic. So I wouldn't necessarily take my my recommendation from WHO. They're just telling people that so they don't jump on the labs to have serologies done, because indeed we really don't know in the community how important a serological test would be. It may be more important, as I said in my talk, in people who are in high-risk areas or people who have the ability to return to work without worrying about getting infected. So healthcare workers, it may make a difference. We'll see how that pans out. Service industry, airlines, pilots, flight attendants, daycare centers, teachers, that may make a difference. But in the community right now, we don't know how to use it, and we don't know what the implications of that is. Whether the immunity is protective, I think the data will show that 99.9% of the time, having antibodies is protected at least against severe disease.
Thanks. One more question, Michael, and then I think we're going to have to move on. So if antibodies are protective, is it true that if you're on biologic medication, your ability to make antibodies against this virus might be impaired?
So yes, that's a great question. I don't know if we know that about COVID. We do know that from vaccines against other diseases. So for instance, in influenza, influenza vaccine, with an influenza vaccine, if you're on an immunosuppressive medication, including biologics, steroids, immunomodulators, you make only about 90% or 85% of the antibody levels. Now, does that mean that you're not protected? No, because clinically, we saw the almost same level of protection in IBD patients who are immunosuppressed as in IBD patients who are not immunosuppressed from having the flu shot. And the same thing with the pneumonia vaccine. But at the laboratory level, so when you look in the test tube, the results show that the antibody levels developed in a person who is immunosuppressed are lower compared to a person who's not immunosuppressed.
Excellent, Michael. That was a wonderful, wonderful talk. And if people have more questions, they can keep sending them in and we can come back to this at the end of the day. But for now, I think we're going to move